Hello, today I'm going to be talking to you about stroke, some risk factors for stroke that are modifiable and that are not modifiable, as well as some of the primary preventative strategies that we are looking at, and also secondary and tertiary treatment that we provide for individuals with stroke. Stroke itself is considered a global epidemic, and that is true in the United States as well. The numbers are projected to increase by 4 million by the year 2030, and that is directly related to our aging population of baby boomers. And as we improve medical care and streamline treatment options and improve quality of care, we will see these numbers continue as the years progress. Stroke itself is considered the fourth cause of death in the United States, and it is the leading cause of long-term disability. The definition of stroke is when a sudden loss of brain function occurs when there is an alteration of the blood supply from a disruption in the blood vessels that lead to or that are within the brain. And the result is a deprivation of oxygen and glucose to vital brain tissues, and that is considered ischemia when you have tissue death. Whenever an individual is having the signs and symptoms of stroke, early recognition of those symptoms and seeking prompt medical treatment can significantly lessen the degree of disability that an individual sustains, as well as it can help prevent potential death. And that is directly related to the fact that brain tissue is very fragile and requires a constant supply of oxygen and glucose to prevent neural death. Because of the disability that occurs with stroke, in 2010, they estimated the medical care cost for stroke to be $73.7 billion. As we see more individuals aging and the incidence of stroke increasing, there is an estimate that between 2005 and 2050 in the United States, there will be 2.2 trillion medical care costs for ischemic strokes alone. And so while these are sobering statistics, over a third of strokes are considered to be preventable by modifying certain risks, by changing certain lifestyle habits, and then with aggressive management and monitoring of certain disease processes such as atrial fibrillation, diabetes, and blood pressure. With the signs and symptoms of stroke, and again, we talked later about TIA, this symptoms and the signs of stroke will vary, and it is based on the area of the brain that is experiencing the ischemia, or the deprivation of oxygen and glucose. And so the brain itself is considered to be the master command center of the body, and it is divided into two separate hemispheres. There's a right and a left. There's the cerebral cortex, and that has the parietal lobe, the Wernicke's area, occipital, temporal, frontal lobes, and then the Broca's area. And all of these contain cranial nerves, which help to send signals to tell the body what particular function. So, for example, in the frontal lobe, The personality, problem solving, conscious movement is significant. If a patient is experiencing a stroke in the frontal lobe, you may see them unable to consciously move their arm. Or if a patient suddenly has visual disturbances, it may be from a stroke occurring in the occipital lobe. So directly the area of ischemia that occurs in the brain helps us to determine where the event is occurring. And so some of the signs and symptoms that we see that occur frequently when a patient is experiencing a stroke is sudden numbness and weakness of an extremity or one side of the face or the other. Typically, it is one side or the other. It does not typically affect both sides. We'll see someone having a sudden confusion, trouble understanding what you're saying, slurring of words or difficulty speaking, a hesitancy with speaking, sudden blindness or inability to see or blurring of vision in one or both eyes. We may see someone become very dizzy, almost like they're going to pass out, have trouble walking, have no balance or coordination. And also if they suddenly have a very severe headache that has a rapid onset with no known cause, this would be another reason that we would encourage a patient to seek immediate medical attention. And we use this acronym FAST, and that is to help caregivers to early identify symptoms when they occur. The F stands for face, so any type of facial disturbances, inability to smile. A stands for arm, or basically that's for extremity weakness. S is for speech disturbances, and then the T stands for if those symptoms are occurring, to call 911 for timely medical intervention. There are two major classifications of stroke, and 90% of the strokes that occur are ischemic in nature, and then the other 10% are hemorrhagic in nature. Another occurrence that we see, and it is similar to a stroke, is a transischemic attack, or a TIA. And TIAs mimic strokes in that you will see some of the same neurological deficits that you do with a hemorrhagic or ischemic stroke. However, the symptoms resolve spontaneously within a few minutes, usually within 1 to 2 hours. But these symptoms can last up to 24 hours without any permanent disability or damage to the brain tissue. And while the symptoms resolve spontaneously, we consider this to be a very serious warning signs, as TIA is a risk factor for developing a more serious event with permanent damage from an ischemic stroke. Ischemic strokes are classified further as thrombotic and embolic. And to help you understand the difference between the two, thrombotic stroke occurs typically, what happens is that inside the vessel, usually within the brain, conditions that harden the wall of the vein and make them narrower, and plaque buildup can occur from the aging process. Proteins deposit, making the veins more hard and immobile. They also thin out, and platelets are sticky. They can form a clot on some of those deposits and those proteins that are on the vein wall, or it can just simply be atherosclerosis and buildup of lipid type material inside these smaller vessels in the brain over time. And it may get to the point that a clot or a thrombosis from plaque buildup will block off a major supply of vessel to the brain. And what happens is this brain tissue, is made up of neurons, and neurons are very fragile, and they require a constant supply of oxygen-rich blood and glucose to maintain their function, and neurons are unable to regenerate. So like skin cells and things that regenerate, our neural tissue does not. And that's what makes the stroke incidence so devastating in many cases, because once the damage has occurred, it cannot be redone. And so this is why we say early intervention is key to get this blood supply reestablished so that further tissue damage does not continue. And an embolic stroke typically is from a piece of plaque or a little blood clot breaking off, and then that blood clot or that piece of plaque migrates up to area in the brain, blocks it off the same way as a thrombotic incident would, and deprives the tissues of the vital nutrients that we discussed. Now, a TIA, what happens, and the theory for why this happens is that maybe it was just a very small little fleck of the plaque that had broke off, lodged in a vessel, but then was able to move on. And so therefore the blood flow was reestablished and permanent tissue death did not occur. With a hemorrhagic event, we consider that to be intracerebral and subarachnoid. Now, the brain is very fragile, and so it's encased in some very tough layers, and those layers are the arachnoid space. The dura mater is the outer layer. The arachnoid is the middle layer. That subarachnoid space is the area where all of the major vessels are housed within the brain and supplies it with the vital nutrients. And what happens with different disease processes like diabetes causes hardening of the vessel walls, blood pressure, constant pressure on these walls makes them fragile and can harden the vessel. And what can happen as individuals age, typically it is an advanced age that this incident occurs, is that there is almost like a herniation in the vessel wall, and so you have these little outpouchings. Sometimes you may hear a term called AVM, or arteriovenous malformations, and that's kind of like a little collection of these tiny little vessels that have kind of bulged out. And what happens maybe from an increased pressure, from blood pressure exerting pressure on these fragile outpouchings, or if someone sustains a violent trauma to the brain, such as from a motor vehicle accident or a blunt force trauma from something falling on these fragile areas, these outpouchings or aneurysms burst, and then the result is that blood begins to accumulate in the space in between the brain and this casing. As individuals age, they're at even higher risk for a larger collection of blood to occur, because the brain does atrophy, or it gets a little bit smaller as we age, and so that makes a greater space for blood to accumulate. Now, the brain and the central nervous system is very sensitive, and it attempts to achieve homeostasis at all times. And so as there is a collection of blood that is occurring, things begin to shift, and it is from tissue swelling and then just the collection of blood itself. We see that tissue and blood will displace the blood vessel and essentially close it off depending on the degree of the hemorrhage. And the result is the same as over here with the ischemic stroke. There is a block of vital nutrients to the brain tissue death occurs, and we see the neurological deficits that are similar, or if not the same, as what we are seeing when a patient comes with an ischemic stroke. And this is one reason why when a patient first comes in, one of the very first things that we do is we send the patient immediately for a CAT scan or an MRI to determine the difference between ischemic or hemorrhagic, as the mode of treatment is going to be different. With an ischemic stroke, we are going to attempt to give thrombolytics to dissolve the clots or the plaques to establish the blood flow. Certainly that would be would definitely be contraindicated in a hemorrhagic stroke, as the patient's already bleeding, and that would prevent a clot from forming, which would stop the bleeding. And so often these patients are going to either have a reversal of if they are anticoagulated, or they may need surgery to clip the aneurysm or to do an embolectomy to block off the supply of the blood that is causing the hemorrhaging, and that is causing the displacement of the tissues. There are certain non-modifiable risk factors, and I briefly discussed the advancing age and the vessel changes that occur. Increased incidence of stroke occurs in those that are age over 65. However, we do see even significantly more increased incidence of mortality in individuals that are over 75. So the older that you are, typically the greater the chance of death when you suffer from a stroke. The other increased incidence that occurs is when you have a family or a personal history of stroke. Certainly family contributes to a genetic factor, such as genetic factors for hardening of the arteries or for weaker vessels. Different risk factors such as high blood pressure, diabetes runs in families, and those are issues that we will talk about in the next slide that can contribute to stroke risk. Personal history of stroke, actually people have a third greater chance of developing a subsequent stroke when they have suffered from one. So it is important that anybody that has suffered from a stroke receive aggressive stroke education and their risk factors, and that if these signs or symptoms occur, to seek immediate treatment. Gender is also a risk factor, and there is actually an incidence of 55,000 more women per year than men have stroke, and their chance of mortality is greater as well. The theory for that is the older we are, the more fragile and the greater the mortality rate with stroke, and so therefore many women have a longer lifespan than men. And so when you look at the statistics, typically women are older than men when they incur their first stroke. The other factor that we cannot modify is our ethnic background, and African Americans are twice as likely to suffer from a stroke as Caucasians and Asian populations, and some of that can certainly also potentially be explained by other risk factors that they have a higher incidence in, such as diabetes and high blood pressure. Also, Alaskan Indians also have a higher risk of mortality and stroke incidence than Caucasians. Hispanic ethnicities as well are in a higher risk factor or higher incidence to incur stroke than the Caucasian and the Asian populations are. High blood pressure, diabetes, atrial fibrillation, and atherosclerosis are all disease processes that we can do secondary prevention of, and to modify the risk factors of these diseases to help prevent stroke. Some primary prevention methods that we can help modify are managing cholesterol levels in patients, inactivity, a patient's weight. Of course, that is contributed often to an unhealthy diet, as well as the devastating effect that smoking has on many body systems that contribute to stroke use incidence. And then illegal drug use, specifically cocaine and amphetamines, increase stroke risk significantly. Alcohol use as well, if it is used in excess, is also a determiner for increased stroke risk. As we talk about high blood pressure is considered a silent killer in that it often is causing damage, and individuals are completely asymptomatic with this disease process. And so high blood pressure in itself is considered a systolic blood pressure over 140 and a diastolic pressure over 100 for a sustained amount of time. And as that blood pressure is exerting pressure on the vessels and making the heart work harder, scarring occurs along the vessels, and the scarring then contributes to plaque buildup along the vessel walls. Hypertension is considered the leading and most important modifiable component to prevent stroke. And that includes a hemorrhagic and ischemic, because high blood pressure is present in over 80% of all strokes that occur. And so managing blood pressure by monitoring aggressively and medicating to keep the blood pressure in the desired range is definitely a way that we can prevent strokes from occurring. In the African American population, they have a 1.5 to 2 times greater chance of high blood pressure being present than in other ethnicities. Also, Hispanics have a higher incidence of high blood pressure than Caucasians and Asian populations do. And one encouraging study that was done showed that when high blood pressure had been managed and blood pressure levels were systolic less than or at 120 and a diastolic between 60 and 80, that African Americans had the same risk of stroke as Caucasians did. And so that was very encouraging in that managing blood pressure alone can help significantly reduce incidence of stroke. Diabetes is disease process that causes elevated blood sugar, and elevated blood sugar over time leads to hardening of the arteries. Hardening of the arteries leads to peripheral vascular diseases and can significantly cause blood pressure in the carotid arteries specifically. And the carotid arteries are again the major arteries that supply the blood supply to our brain. This disease also encourages or can increase the incidence of blood clots forming, and so increases the chance of embolic stroke. Interestingly enough, when a patient comes in with stroke symptoms, we do check a glucose level, because often if a patient is hypoglycemic or has a low blood sugar, they can present with stroke symptoms when actually it is from a lack of glucose from their diabetes. So often determining that it's a hypoglycemic episode, treating the hypoglycemia will resolve the neurological deficit. Atrial fibrillation, let me get to that slide, is a condition where there's a disorder in the AV node, or the electrical conduction of the heart, and it causes the atria to asynchronously contract with the ventricles. And what happens is we get a swirling effect up in the atria, which platelets then begin to aggregate, and you can have the development of tiny little clots, or you can actually have formation of clots or thrombus against the atrial wall. And as this condition occurs, these little plaques or the clots can break off of the thrombus, or little clots themselves can be pushed through and migrate up into the smaller vessels in the brain and cause the blockage. Now, we've been talking about medical management, and with atrial fibrillation, the treatment would be antiplatelet medications, but also anticoagulation is recommended in these individuals. When a patient is anticoagulated, it can reduce the risk of ischemic stroke by 67%. And atrial fibrillation occurs most frequently in those that are aged over 65, and it's actually present in 1 in 4 people that are over the age of 80. So the particular challenge with giving anticoagulants are that when we reduce the risk of ischemic stroke, we actually might increase the risk of hemorrhagic stroke, because as we thin the blood out, areas that are fragile in the brain that may be susceptible if there is increased blood pressure to those vessels rupturing, that patient's at a much higher risk of a hemorrhagic stroke then. So we do find that physicians are sometimes hesitant in some of the very elderly patients that suffer from dementia and are at higher risk for falls to be anticoagulated. With atherosclerosis, and we've been talking about this, and here in this particular diagram it shows it a little bit better. It is actually caused with cholesterol levels. So these two risk factors kind of go hand in hand. And so cholesterol level, specifically what we're talking about, is the LDL, or the low density lipoproteins. And these lipoproteins are very, very sticky. And as the levels of lipoproteins that are circulating in the blood build up, they begin to stick to the walls of the vessels. Over time, as these areas are building up with these lipoproteins, yes, the buildup does reduce the blood flow. They turn into very hard plaques, and it's when these lipoprotein buildup, when they become very hard, then we call that atherosclerosis. Now, atherosclerosis, as it hardens the walls of the vessels, sometimes because of the hardening, areas can crack, or you get fissures in these little areas of plaque buildup. And as they crack, the body, of course, platelets will aggregate in the area to prevent the hemorrhaging. And because the vessels are already narrow, when the platelets build up in these areas, then it contributes to the rest of the vessel being occluded, and then you have your subsequent ischemia that occurs, and we see then the neurovascular deficit, and a stroke has occurred. Now, with cholesterol levels, certainly encouraging patients to eat a diet that's low in saturated fats, being active, exercising 30 minutes on a routine basis daily can significantly reduce cholesterol levels. But often when the LDL level is over 100, it is recommended by the American Stroke Association for the patient to receive a cholesterol medication, specifically a statin, and that is to reduce the cholesterol level and the stroke risk from these plaques from forming in the first place. Obesity as well is a contributor and is listed as a risk factor simply because obesity, and that is anyone with a BMI, or a body mass index, over 30. Obesity contributes to coronary artery disease, diabetes, and high blood pressure, among other problems. And so it also, because it contributes to the incidence of those diseases, it contributes to stroke risk as its own risk factor in itself. Ideally, recommendations are that we keep our BMI 25 or less. Anyone that has a BMI between 25 and 30 is considered overweight, and so your risk is starting to increase at that point. Now, smoking. Smoking in itself is affects many different systems of the blood. Smoking increases blood pressure. It makes the blood more coagulable, so it contributes to clot formation. It can contribute to cholesterol buildup on the walls. It decreases the oxygen supply of blood to the walls of the veins and the arteries, and so smoking is considered to increase the risk of stroke by 50%. One of the factors and the statistics that we have also found is that there's a higher percentage of African Americans that smoke as other populations, and so that can be another reason that we may see that the African American population may have an increased risk for stroke and mortality associated with that. Illegal drug use, cocaine and amphetamines certainly can dangerously increase heart rate and elevate the blood pressure, and it is from those two situations occurring that these illegal drug use can cause stroke. Alcohol use in itself is a balancing act, and so 1 glass of wine a day is not considered excessive, but the recommendations are to prevent or to limit yourself to 1 or 2 drinks a day. Stroke, depending on where it occurs, of course, can affect many different systems. Of course, it affects the neurological and the vascular systems, but when these issues occur, it can affect the gastrointestinal and musculoskeletal function. And specifically, different cranial nerves affect our ability to swallow. And so a decreased ability to swallow is called dysphagia. And this is a secondary measure that we try to prevent complications from stroke. And specifically, when dysphagia occurs, it may occur from a mechanical and a neurological issue going on. But what we find is there is paralysis sometimes of muscles, and the normal swallow reflex, we find the epiglottis closing as food is forced into the esophagus. And when a patient suffers from stroke, this motility, the muscular contraction of peristalsis, as well as the cranial nerves that affect the glossal function, can be slowed or absent altogether. And so instead of the epiglottis closing to prevent food from going down into the lungs, the mechanism does not work either fast enough or work at all. And so as a patient swallows liquids or food, this can migrate down into the lungs. And the reason that is a significant issue in the stroke population is that dysphagia can result in aspiration pneumonia. And so if a patient survives a stroke, they may actually end up dying from an aspiration pneumonia if we don't adequately manage and treat this issue. Also, the decreased swallow can result in a decreased amount of fluids that the patient's able to drink, food, and so that also contributes to dehydration and malnutrition. And so in these patients, we want to monitor, and dysphagia can happen up to 3 days after a stroke occurs. And So the medical management would be oral exercises, perhaps just thickening food so that it moves slower down if it is simply just a slower motility issue, or some patients in severe issues that have lost all of their ability to swallow may require feeding tube or gastrostomy to receive their nutrition and fluid requirements. As far as the musculoskeletal system, we see that depending on where the stroke occurs, paralysis of extremities, of facial muscles can occur if there is significant paralysis. You can have atrophy of muscles. The lack of coordination can contribute to falls. As the older we get, our bones are more fragile. A higher incidence of osteoporosis can occur, and so we see a higher incidence of fractures. Falls and fractures in the elderly can also contribute to mortality rates, but we also can see paralysis of the bladder and bowel muscles, and so we can see resulting incontinence. Here again, we've got the FAST acronym that shows facial drooping, arm weakness, speech difficulties, and then calling 911. It is key that if a patient is experiencing these symptoms to call 911, the sooner that we give antithrombolytics or perhaps surgery for a hemorrhagic event, the greater chance and the less amount of disability the patient will have. When a patient is experiencing a stroke, the cranial nerves cross near the brainstem, and so if a patient is experiencing a stroke on the left side of the brain, the muscular function and the coordination and the effects that you may see are actually on the opposite side of the body. So if the left side is damaged, you're going to see neurological deficits on the right side, or the symptoms are going to be on the right side. And the same is true if damage is occurring in the right hemisphere, you're going to see effects typically on the left side. If you're seeing effects on both, it may be that there is a very severe perhaps a hemorrhagic stroke that is causing pressure on bilateral hemispheres. And of course, that would make the mortality and the outcomes significantly secondary prevention and treatment. Once a patient has been shown to have a stroke and they come into a hospital for medical care, into the emergency room, as I discussed earlier, of course, we're going to get a CT to rule out a hemorrhagic or a ischemic event. Certainly, depending on what we find with the results of those scans, will determine if neurosurgery is needed for the hemorrhagic event, or if it is ischemic, if the patient qualifies for thrombolytic therapy. TPA is to be given within 3 hours of the symptom onset. Some statistics show that there is some benefit up to 4.5 hours, but the best outcomes are when we give these clot busters within 3 hours. Whenever we give these clot busters or alteplase, there is an increased incidence of hemorrhagic events developing, even though originally they are classified as an ischemic stroke. And it's sort of the same principle as when we're giving anticoagulation for atrial fibrillation. It just increases the risk of hemorrhagic events. So after we give this, and even when a patient first comes in, we're going to do frequent blood pressure and neurovascular checks the first 24 to 48 hours, because it is in this area of time when the patients are at the greatest risk for their stroke extending or from suffering from a hemorrhagic event. We talked about doing dysphagia screening in the prior screen, and so we would do a quick bedside swallow screen to ensure that the patient is able to swallow, and that is to prevent aspiration and other complications. And if the patient is not able to swallow, you would keep them NPO or nothing by mouth and do dietary modification as recommended by the speech language pathologist. When a patient first comes in, we also monitor the CBC to ensure that the hemoglobin is not low, that they don't need transfused. We check coagulation, especially if we need to reverse something, if a patient's on Coumadin, or to evaluate if we can give thrombolytic therapy safely. Checking the lipid panel to see if their cholesterol levels are high. And again, as we talked about, hypoglycemia can present as with stroke symptoms, so we always check those glucose levels as well. Then once we get past the initial phase, once the patient is hospitalized, if they're not already on it, they're going to be started on antiplatelet and antithrombotic meds to help prevent platelet aggregation. If they have a history of AFib, they very well are going to be discharged on an anticoagulation medication. LDLs over 100 are going to be prescribed anti-cholesterol medication, and then the patients are going to be prescribed physical therapy, occupational therapy, and speech therapy, because as we talked about, depending on where the stroke has occurred, you're going to see neuromuscular deficits, which can affect a patient's activities of daily living, as well as speech and nutrition. It is certainly a condition that affects the entire body. If a patient comes into a rural area and a neurologist is not on staff, some of the latest guidelines with the American Stroke Association and the Brain Coalition are that telemedicine or teledocs be used to help determine if a patient is a candidate for TPA therapy. We call strokes a lot of times a brain attack because it is very similar to a heart attack, and that time is of the essence. And so getting a patient that blood flow reestablished with thrombolytic therapy is so key in their long-term outcomes. And so utilizing type of Skype or iPad technology so that a physician that's off-site can visualize the patient, ask questions, in conjunction with interdisciplinary healthcare members that are at the location, such as RNs, ER physicians, and can definitely help speed up the timely and efficient way that we administer a stroke protocol. When considering post-stroke and some of the tertiary treatments and long-term management of diabetes and helping educate on the effects and how to manage diet and blood sugar levels and can help decrease stroke incidence, managing blood pressure and monitoring and keeping a log of that, as well as anticoagulation, monitoring the PT-INR levels are certainly all important factors when we talk about disease management. But stroke support groups and even your cardiac rehab and stroke rehabilitation programs are significant in giving patients post-stroke and their caregivers education that they need to adequately manage their particular risk factors and their disease processes so that they can decrease their risk of stroke. Smoking cessation support is so important for those that are smoking because it's so difficult. Nicotine is a very addictive drug, and so being able to talk about issues with support groups have been shown to be very beneficial, as well as smoking cessation meds to wean slowly off, so that the withdrawal from nicotine it does not stress the system quite so bad. I put here at the very end of this presentation, this is an app that you can download onto a smartphone, and if you have any members or patients or caregivers that have a smartphone or a little tech savvy, this is really an awesome app in that you can get it on the American Stroke and Heart Association website, but it uses the acronym of FAST, and the caregiver or even the patient can hit this call 911 now if they are having symptoms, and it immediately calls 911 and it starts a time clock so that we know when the patient gets to the emergency room exactly how much time has transpired so that we can safely give medical treatment. It also, the patient or their caregiver can click onto what is a stroke and what the signs and symptoms are here. There's helpful resources that are linked here in this particular bar. And it just helps to solidify, in conjunction with different support groups, some of the teaching that perhaps they did not retain when they were in an inpatient environment. And so this concludes my presentation on stroke and risk factors, and I hope that it helped you, and I hope that you can use this information to go and utilize it out in your communities. Have a wonderful day.